everybody. Thank you for the opportunity to be here, and I hope this presentation in some way is helpful for all of you in your practice. So let's start. So the term arthrodesis was described initially in the 1800s, and it was done by a surgeon in Australia, Dr. Albert back then. But it wasn't until 1930s when the first ankle arthrodesis was described. The goal of ankle arthrodesis is to achieve a painless functional ankle during the gait. However, in order to achieve that, we need successful union and, of course, in an optimal position. However, the non-union rate in these patients are specifically for primary arthrodesis are between 0 and 15%. And then when we go in cases where there is a revision, whether it is because primary arthrodesis was performed or any other complication happened after the arthrodesis, the non-union rate goes up to 23%. Overall, it's a good procedure, and patients are meet the expectations after the surgery. But it's good to keep in mind certain changes in the gait of the patient after the procedure. Usually the gait velocity decreases up to 16%, and about 20% of the patients can develop adjacent arthritis. Fortunately, this is more related to radiographic adjacent arthritis, which means that a lot of them won't need any additional treatment, specifically surgical treatment for these adjacent arthritis in the foot. Indications for ankle arthrodesis. So the main indication for ankle fusion is destruction of the tibio-talar joint. That being post-traumatic arthritis, the main cause of the destruction, we have also other causes, including chronic instability, rheumatoid arthritis, or any severe inflammatory arthritis as psoriatic arthritis or chronic neuropathy, whether it is related or not to diabetic patients. In cases of failed total arthroplasty, and this is something that we need to consider in mind, especially with the number of total ankles that we have been doing lately, the number has increased, and therefore the complications also can increase. In these cases, ankle arthrodesis is definitely a procedure that can help these patients. In terms of septic arthritis or any infection in the ankle joint, or patients with avascular necrosis of the talus. In cases of rigid deformity, when any other procedures as muscle tendon rebalancing is not possible. Primary arthrodesis for tibial pilon fractures is also the main indications for this procedure. These are the cases where we have fractures that are severely comminuted or severe bone loss due to an open fracture. There are other indications of the patients with delayed definitive treatment. We see this in patients with polytrauma who is not possible to do the open the open reduction, the internal fixation, up to 3 or 4 weeks after the injury. In these cases, it's very challenging to do anatomic reduction of these type of fractures, and that primary arthrodesis have better outcomes in these patients. In other cases where the patient has medical comorbidities, where we would rather to have just one single shot, but a very, very good surgery for the patient that will avoid subsequent surgeries, we should also consider primary arthrodesis in these cases. When we talk about the contraindications for ankle arthrodesis, I consider most of these relative contraindications because some of them are treatable or do not contraindicate the procedure entirely. These are patients that are unable to be cleared for surgery secondary to medical issues. In cases of uncontrolled diabetes or poor nutritional status, patients with severe perivascular disease, or with active smoking. We all know that active smoking can increase the risk of non-union up to 3.5 times compared to patients who don't smoke. Active infection is more a contraindication for internal fixation, and in these cases, external fixation is strongly recommended. In terms of risk factors for complications and non-union, the spectrum of these are significantly wide. In terms of systemic factors we have, and what the literature have shown us is that tobacco use can increase the chances of non-union up to 54% in those with active smoking. Cobb and colleagues also show us in a study that the relative risk of non-union increases 3.75 times higher in those patients who were actively smoking compared to those that are non-smokers. Diabetes is also related to complications, although the physiopathology of why diabetes impairs bone healing in humans is not completely understood. We know based on clinical studies that there's a higher incidence of non-union and is about 18 times higher likelihood of various malunion. When we have a malunion, this also translates in poor outcomes. In terms of other factors as alcohol abuse and obesity, it seems like this is more related to as a secondary cause of these complications due to the association of these factors with osteopenia, difficulty with getting the patients to be compliant with the non-weight-bearing status after the surgery. And in cases of patients with that are morbidly obese, it's sometimes difficult to get an appropriate cast fitting or even a brace, which in other words, makes more challenging for the patient to be compliant with the post-operative protocol. Other risk factors, but that we don't have strong evidence for this, are workers' compensation patients, which usually are related to decreased functional outcomes, and patients without immune suppression status or advanced age. In terms of local factors, patients with bone loss or compromise of tissue envelope, these are usually combined together in patients with open fractures. This in some ways can result in a vascular necrosis, infection, and this definitely decreases the chances of non-union, Neuropathy, whether it is associated with diabetes or not, is also related to an increased risk of complications, not only in patients with ankle arthrodesis, but also with patients with ankle fractures. In terms of historical factors, the stability of the construct to achieve a good opposition between the two fragments are also related to increases risk of non-union when none of these are achieved. In terms of surgeon factors, there are some studies that have tried to assess and compare patients with surgeons with high volume versus low volume. What they have found is that patients of surgeons with a high volume has better functional outcomes, but these studies has no evaluated specifically the rate of union. They're more has been directed towards functional outcomes, so we might have a little bit of bias here. For all these patients, they need appropriate evaluation, and we should pay a specific attention to the integrity of the skin, if there is any presence of prior incisions, and also assess the location of these incisions. The vascular status of the patient is very important to determine the possibility of complications, and if there is any severe deformity or any malalignment. In terms of range of motion, this is going to be helpful for the patient outcomes, specifically of the range of motion of the subtalar joint and the tarsal joints. All these parameters will determine your appropriate planning in terms of what surgical approach, any associated procedures in cases of if the patient has any contracture, for example, in equinus, the patient will need an Achilles tendon lengthening or a stretcher procedure to achieve an appropriate position of the arthrodesis, and ultimately to determine the type of fixation for these patients as well. The optimal position for a tibial arthrodesis are 0 degrees of dorsiflexion, up to 5 degrees of hindfoot valgus. And in terms of external rotation, we can tolerate up to 10 degrees, also always keeping in mind that the transverse plane should be in line with the normal malleolar axis, and also try to evaluate the contralateral limb. This is going to be very helpful when you are going to obtain the optimal position of the arthrodesis. In terms of the position of the talus under the tibia, is recommended up to 5 millimeters posterior translation of the talus. Keep in mind that and I feel these principles are for any type of arthrodesis. And in order to achieve a successful union, we need a good alignment and a good apposition of the vascularized bony surfaces. Once we complete the arthrodesis, we need a rigid fixation that needs to be stable as well. And we also need to provide an appropriate compression across the arthrodesis side as well. In terms of surgical approach, it has been described multiple surgical approaches in terms of like the two big, let's say, approaches that we have is the open approach or the arthroscopic approach. When we talk about the open approach, even since the beginning of the description of this procedure, probably the earliest approach has been the midline anterior approach, which we'll still use. And the transfibular approach or the anterolateral approach are probably the most widely used in this moment in patients that are not suitable for an arthroscopic arthrodesis. The posterior approach is the less used, but it has been described and has specific recommendations and is useful, in my opinion, to know that it's suitable in patients where the anterior or the transfibular approach are not appropriate indications for these patients. In terms of these three open approaches, so we have the anterior approach, which offers a great exposure. It is recommended in patients with deformity in the coronal plane. The downside is that it doesn't provide good exposure to the posterior aspect of the joint. And there implies an extensive soft tissue dissection that can be translated in arthrofibrosis after the whole procedure. The transfibular or anterolateral approach offers a local autograft because you can use the fibula as an autograft for the fusion as well. It's recommended in patients that are in some type of deformity where the talus is completely translated anteriorly. And this is common in patients with an old pelvic fracture. And the advantages of these approaches that expose the joint from the anterior to the posterior aspect widely. The posterior approach is more a salvage approach. Is recommended in patients that have a compromised soft tissue envelope anterior or laterally. In other words, where the other two approaches are not recommended. And in some ways, avoid these all the previous incisions that are related to a poor vascular supply. Arthroscopy approach is probably the most commonly used, of course, when we don't have one of the following contraindications. The first case was reported by Dr. Schneider in 1983. And it should be always keep in mind for any patient that requires an ankle arthrodesis, as long as we don't have the following contraindications, which is a rigid deformity that is more than 50 degrees in the coronal plane. Also, there are some studies that have shown that patients with high experience in ankle and arthroscopic ankle arthrodesis might achieve successful outcomes in patients with a higher deformity. My recommendation would be start with less deformity and progress as you feel comfortable with this approach. Patients with excessive bone loss or poor bone stock, the phone is not indicated, or those with an active infection or any vascular necrosis more than 30% of the talus. It is related to a reduced union time. And general, it says that it takes about 9 to 12 weeks compared to 14 weeks for those patients with an open approach. And definitely is related or has been associated with a decreased postoperative pain. In terms of external fixation, any of the three constructs can provide a stable and a rigid construct as long as we have a patient with an adequate bone stock. In this case, the biomechanical studies have shown that the three constructs can provide a rigid fixation in order to obtain a successful union. In cases where the patient has a severe deformity, severe bone loss, or osteoporosis, and even in cases with osteopenia, biomechanical studies support more the use of plates or an intramedullar nail to provide a more stable and rigid fixation. In these cases where patients are also suitable for a hybrid fixation, in these cases, we can use lag screws, but we can use a neutralization plate to provide a more rigid construct. External fixation is definitely used, but is more used as a salvage alternative to patients that if this wouldn't be the option, the next step will be an amputation. These are usually complex cases. It's recommended in type B host. Patients are defined as patients with a poor nutritional status, any type of immune deficiency, and this includes transplant patients, patients with diabetes, especially those that are uncontrolled, renal or liver failure, active smoking, or chronic lymphedema. In these cases, what the evidence have shown is that is a slightly better outcomes or less risk of complications with external fixation. Patients with Charcot arthropathy, an active infection, and in cases of total ankle arthroplasty, especially in those that are associated with an excessive bone loss. In terms of outcomes, in general, with ankle arthritis, when we are facing a patient with a primary ankle arthrodesis, the fusion rates are significantly good, as we can see in these two studies, even for patients with post-traumatic arthritis or those that require a primary arthrodesis due to a severely comminuted pilon fracture. The fusion rate is up to 91%. The functional scores were slightly better in those that require an ankle arthrodesis for a different cause, that a pilon fracture, but still the functional outcomes of these patients are not that bad, especially when we are facing patients that were involved in polytrauma or any severe high energy trauma. In general, the satisfaction rate is also more than 90%. So I think this talks really positive about the procedure. Now, when we talk about the comparison between open versus arthroscopic approach, what the evidence is showing us is more leaning towards the arthroscopic approach. What is definitely have shown in multiple studies is the patients experience less postoperative pain. They have a shorter hospital length of stay, and even in some patients or some centers are considering doing these arthroscopic arthrodesis in an outpatient setting compared to patients that have an open approach, then most of the time, if it's not all the time, required to stay in the hospital at least for 1 or 2 days. All the studies has also shown a shorter tourniquet time and also a less blood loss. In terms of functional outcomes, there is most of the study has lent more towards better functional outcomes, but the evidence is a little bit weak in those. When we talk about what we still have some controversial results is more in if it actually provides a higher reunion rate or it is actually less complication rate. Some studies have shown that it's less infection, but the evidence is a little bit weak in this topic. Downsides of doing this procedure. Up to 70% of patients after ankle arthrodesis have a complaint of difficulty walking on uneven ground, difficulty with going up and down the stairs. They have to modify the way that they pick up objects from the floor. And there is also evidence of adjacent radiographic arthritis. Why is it important to keep all these things in mind? Because I think it's important to address these things in the preoperative evaluation. There are multiple studies that have shown that when the expectations of the patient are discussed and maybe the expectations of the surgeon, these might increase the satisfaction rates at the end. So it's important to know that this is a good procedure, but definitely has some downsides, and the patient should be aware of those even before surgery. In conclusion, This is an old saying, as we will say, there are multiple approaches. Choose the one that is more suitable for your patient based on the patient's need. Be flexible in your thinking and rigid in your fixation. There are multiple ways of doing an appropriate internal fixation. Do the one that you feel more comfortable with, but also keeping in mind what the patient needs. The best chance is your first chance. So the best chance is to do a rigid and a good position ankle arthrodesis. So that's why this is a procedure that is still indicated as a primary arthrodesis for patients with pilon fractures. If you think that the patient is not gonna be suitable for an anatomic reduction after a pilon fracture, consider to do a primary arthrodesis. Even if they're young, they might have better results and less number of surgeries with a primary arthrodesis. Arthroscopic arthrodesis might decrease hospitalization stay and offer a faster recovery, but is not the appropriate approach for everybody. But if it is appropriate, try to do it and try to expose yourself more to this approach. Significant bone loss, in other words, means open arthrodesis. So you can see what you're doing, and you can actually address the deformity more appropriately. Discuss the surgery expectations with your patients. In those, there is no perfect solution for ankle arthritis or high energy pilon fractures, but definitely this can offer a functional ankle during your gait. Thank you.